Thanks, Sue. Let me get my share screen up here. How's that? Everyone can see that?
Yes.
Okay, good. All right. As Sue stated, this is primarily about telehealth and rehabilitation, talking about concepts, trends, and possibilities in the home in a remote type function. Here's my bio. I'm not going to read it to you. Feel free if you have any questions or concerns to let me know. But I've been a PT for 18 years. I've been a part of the HRSA grant at FUMA on and off for the past probably 4 or 5 years. So it's great to be back and connected with all of you folks. So telehealth, let's just start with the basics. You know, it's using any type of electronic information, telecommunication. I know not a lot of the patients in the home that I'm seeing currently, you know, have a lot of telehealth visits with their primary care physicians, other specialties, and some are live video and some are just over the phone. And there's pros and cons. There's other telehealth type visits, pacemaker monitoring, and you know, the vital sign checks and weight monitoring that, you know, sometimes the patient will have some equipment in the home that will send the results back to a central location, and then, you know, typically a nurse will review it to see if a patient gained weight or they're monitoring their blood sugars or their blood pressure is under control. As far as Tele Rehabilitation and e-rehab, there's quite a bit of information, literature, and research out there. I'd say physical therapy does a pretty good job using primary literature to drive our practice and our practice models. So even before, you know, March of 2020, there was some limited use of Tele Rehabilitation, which I'm going to use moving forward for the rest of this presentation. And it's a number of different things. It can be from PT assessment to just an educational visit, compliance checks on home exercise, home activity programs, developing those programs, and any type of physical therapy treatment can be performed really over Tele-rehabilitation. And if anyone has questions, you know, please feel free to put your hand up or interrupt me. So some considerations for Tele-rehabilitation. I mean, first and foremost, you know, is it legal within your state? Does the state authorize clinicians to perform this service? And the state of Ohio currently does, so that's a good thing. You know, identifying and obtaining informed consent's huge. You know, you have to know the population you're working with. Is it going to be something that maybe you're mailing a packet out in advance to obtain that informed consent and to kind of set the protocols and processes, or could it be done maybe just through email? So informed consent is something that's very important to obtain, especially at the first time meeting a patient and performing the assessment. Making sure you have the right patient. May seem like, you know, kind of a basic idea, but if you've never met Mrs. Smith or Mr. Jones, you're going to need to identify them. And best practice is to patient identifiers. And to the contrary, I mean, the clinician needs to be able to identify themselves as well, just so the patient feels comfortable with who they're engaging with over, you know, the website or, you know, some type of software program. A lot of older folks are not comfortable with that. And, you know, so being able to identify, a couple different ways for the patient. And a PT license number would be one way. Obviously, a name would be the other. As far as the technology that's out there's a lot of different software platforms that can be utilized. The primary thing is something that's going to protect the patient privacy. So, some type of HIPAA compliant software would be ideal to use in the telerehabilitation model. Reimbursement currently, Medicare, Medicaid are not reimbursing for physical therapists. Some private insurances are, and of course, private pay would be another avenue to access patients and to get some type of reimbursement for your service. So we'll move on here. So selection criteria for telerehabilitation. The Veterans Administration is doing a really kind of stand-up job in this, and they usually are kind of on the forefront and cutting edge of, new technologies. They use telerehabilitation currently to reach veterans who are in remote places. So location is ideal when you're selecting a patient. If they're an hour or two away from a local VA, or if they're in, an area that, is just not is remote, telerehabilitation is an excellent opportunity for follow-up after maybe an initial assessment, maybe in person, or just doing the initial assessment via telerehabilitation. Identifying the appropriate patients for treatment via telerehabilitation. So, I just put down some examples of kind of, two different varying types of patient. A patient with hemiplegia that may be ambulatory versus a patient with hemiplegia who's wheelchair bound. So, both patients, same diagnosis. So, just selecting a diagnosis may not be specific enough. You really have to look at it by case basis. The ambulatory patient, we can definitely do something remotely with this individual. Whereas the wheelchair bound patient with hemiplegia, we're probably going to be very limited in our assessment, our interventions, and our treatment of this person, just because they're going to need probably some physical assistance in order to transfer. If they're using a wheelchair, they're not ambulatory more than likely. So it's going to be a lot more difficult, and which would affect the outcomes for that patient. A post-op total hip arthroplasty versus a post-op BKA. The post-op total hips they're pretty straightforward these days. The surgeons, in my opinion, want to put us out of business, but the approach is much better, whether it's anterior lateral or posterior lateral. Smaller incisions, recovery is a lot shorter. So, typically you would be able to address, gait, balance, strengthening with that individual. Post-op below knee amputation, probably more difficult. Again, they're probably going to be using, non-ambulatory, using a wheelchair for primary mobility, difficulty with transfer. So going to require hands-on assessment and treatment and intervention for this patient. But as far as, maybe following the wound of the below knee amputation may be ideal. Hey, are you wearing your post-op shrinker? Are you doing the right things as far as taking care of that skin and the skin integrity? So if we're looking at it from that perspective, that could be very doable via telerehabilitation. Next kind of comparison, a patient with falls versus a patient with Parkinson's. So we have patients, again, need to be very individualized and assess each specific patient. Patient with falls, maybe, a trip on a rug or over a small animal. But maybe that's maybe one or two in the past 6 months or a year. Something we could probably work with. Patient with Parkinson's disease, we're going to need to probably be there a little more hands-on. Although we could probably benefit that patient a little bit, maybe with some environmental changes or some tips on, using a walker or different types of assistive devices. Probably not going to be able to really impact or make a significant change with the patient with Parkinson's disease. Another example, musculoskeletal, low back pain versus knee pain. Low back pain, we follow some different pathways, whether it's a flexion or an extension type of injury. Does it hurt to stand? Does it hurt to sit? Or using ice, heat? We can kind of walk patients through, some low back pain treatment, assessment, repeated activity and standing, sitting, things like that. And we can kind of get to kind of an underlying cause or origin for the back pain. Knee pain, now it's probably going to be a little more difficult. We've got the patellofemoral joint, we've got the femoral tibial joint. We've got a lot of different structures within the knee. So the knee may be a little more difficult to isolate and to address. But again, we can start with the initial, NSAIDs, ice, compression, elevation. So we can address some of those acute, subacute phases of the injury. But long term, we may not be able to, really assess, is it maybe an MCL sprain or an ACL, or is it, a meniscus injury, or is it just really just kind of some soft tissue injury with maybe some effusion in the joint? So again, a little more difficult. So again, just selecting the appropriate patient, I think, is really going to be key in whatever type of tele-rehab or telemedicine that you're going to be pursuing with the individual. Patient with mental health issues. I was reading an article yesterday, patient with maybe agoraphobia or anxiety who doesn't like to leave their home. This could be something that, we could work through over Tele Rehabilitation, get them on a good exercise or activity program to help with their day-to-day mental health issues. So driving that physical activity and helping with the balancing some of the chemicals in the brain, in addition to medical intervention. Patient with dementia, unless there's a caregiver there, you may not have real good compliance. You may have some issues, of instructing the patient, getting the patient to perform the right activity. A lot of times these folks just need a little more one-on-one, hands-on. The screen or the telephone may be, something that an obstacle that they just may not be able to overcome on their own. And that's okay. So just unless they have like a caregiver present, so that would be a huge support for that patient with dementia in the home. So, hopefully most of our patients have some type of caregiver support in the home. And if they can be present during the tele-rehab visit, that would be very instrumental in the success of the session and of the entire plan, including interventions, treatments, and all the way to discharge. So again, just looking at a lot of different things as far as selecting the appropriate patient when you are performing this type of service. So the initial, nothing changes as far as when you do telemedicine. So, you still have to have a physical therapist, do the assessment, establish the plan of care, work on the goals, interventions, the frequency. So we're going to perform it twice a week, 3 times a week for 4 weeks, or is it going to be once a week for 4 weeks or 6 weeks? So, we still have to follow our practice guide. And the plan of care must be patient specific, and then, follow any physician or surgeon protocols. Um, nothing changes as far as that goes within our Practice Act. Um, and referrals from physicians, of course, would take into account any specific frequency and duration as well. Moving on. So really the Tele Rehabilitation, whether you're in an outpatient setting, working with a patient in their home, or if you're a hospital-based um, physical therapist, it's providing you with that footstep inside the home and the life of the patient. Um, you know, I always say, being in home care, we always use our senses to kind of see what's going on in the home. So nose, hear things, obviously you see things, but just kind of evaluating the environment is significant piece to what we do. And telerehabilitation is kind of the same thing. So, for example, patient appearance. So, this patient knows that they have an appointment coming up. They're going to be on video, and, maybe they didn't comb their hair, put their dentures in. Maybe they don't have glasses on, and they're saying, "Hey, I'm having a hard time seeing you." So there's just a lot of things that you can assess kind of at first glance with the patient, just including their appearance, completion of ADLs, and things like that. So again, using our senses. If the patient has some type of mobile device, whether it's an iPad or a laptop or a smartphone, hey, can you kind of show me where you spend a majority of your day? Do you have a favorite chair that you sit in? Can you show me how you get in and out of it? Is it a power chair? Can you show me where you sleep at night? So again, just kind of having the patient give you a tour. I always say it's kind of like a nickel tour. If you're ever watched a lot of realtors will do a little, 90-second tour of a home on social media. That's what I'm looking for. Would just be kind of a short, concise, kind of take me through the house where you go. I'm not looking for someone to go down the basement and show me where their furnace is. That's not really important, but it's really important where they spend their time, where they sleep, their bathroom, and just get a feel for, the patient's home and what maybe some of their obstacles, challenges, safety issues are. And again, you can really identify, what's the lighting like, is there some clutter around the house, so really just basic environmental issues. As far as, assessing a patient's function. So again, in order to do this, you've had to select an appropriate patient. So let's just go for our conversation, a patient who has fallen, mid-70s, doesn't use a cane, doesn't use a walker, has fallen a couple times. He or she says it's because they're clumsy. So we know we're dealing with someone who's a little more high functioning. Maybe he's on some medication for some general medical issues, high blood pressure, cholesterol, depression, but they're not taking anything else. Real simple. I mean, you can have a patient stand up. You can assess their posture anterior. You can ask them to turn to the side. You can see their lateral view of their posture, and you have them turn around to the back. Okay. Range of motion can be real easy, and I can't see myself, but can you put your arms up? Can you get to the back of your hair if you had to comb your hair, or do something back here? And then the next one would be, can you tuck your shirt in on each side if you needed to? Okay. So that's a quick screen, and that I would call that an upper quadrant screen, looking at range of motion and looking at strength against gravity. So we can say that that's pretty functional right there. You can ask the patient, hey, set up your camera device, and can you walk away from me and then turn around and walk back to me? So we're assessing gait. Can you show me what kind of shoes you wear? So you can have them take off their footwear and actually show you their footwear. I don't have my shoe here, but I have a cell phone. You can have them show you their shoes. You know, a lot of people, you'd be surprised, you know, they're wearing slippers with no back, or, you know, little ballerina type slippers that don't have any support. And, you know, these people are tripping and falling and having issues. Assistive device, you know, do you have a cane? Well, I have a cane that has the 4 prongs on the bottom. And the last time I used it, I hated it because it feels like it's throwing me off balance. Well, okay. First thing in my mind is that quad cane, we call it, it's too much of an assistive device. So maybe something more that was like a single cane, or maybe a single cane, and they have these different feet you can put on the bottom. Hurricane is the one on TV that everyone talks about, and I don't support or endorse those. But you can get little feet, and they can be like about, you know, 4 or 5 inches around, and they give a little more stability than just the straight cane with the small little end. But maybe that's something that would be worthy of pursuing for that patient. And again, inspecting any type of wound, incisions, or edema. So there's a lot of things that kind of can be done, you know, on that kind of that first assessment to kind of establish that plan. And then hopefully there's a caregiver there, a spouse, a son or daughter, relative, that you can kind of talk to along with the patient. Say, hey, you know, is that accurate? Is that what you recall during the events that happened during this person's fall? You know, where were they? Was it morning, noon? Was it night? So going over just kind of a lot of the setting and situation. And then just knowing that there's a caregiver there for follow-up compliance issues. It's really important. I learned early on in my career, you know, what a patient does 23 hours of the day when they're alone versus the hour you're with them is really more important than what they're doing almost when they're with you. I mean, they're learning, and they're gaining strength, and they're doing things, but if they're going to go home and sit and put their feet up for the other 23 hours, then, you know, we're probably not going to make a lot of progress. So we talked a little bit about the upper quarter and lower quarter. Lower quarter would be the same thing. Just see that their foot and ankle moves up and down. If their knee straightens and bends, see if they move their hips together and apart. So we're just looking at some, you know, general gross range of motion and strength. You know, based on the primary complaint, you know, physical therapy again has done a nice job looking, you know, literature, standardized tests. There's lots of tests out there that can be filled out as questionnaires. They can be performed, you know, again, if you're picking, you know, an appropriate patient to go through these tests. So, you know, the Oswestry low back pain disability questionnaire, that would be something that I could fill out for the patient, just have them ask questions. Hey, you know, what's your back pain like today? When is it the worst? And morning, noon, or night? And so you go through the questionnaire, and so then you've got some objective data. You've collected some information on this patient. The Berg balance test, you know, it's kind of having them stand up and sit down, you know, 5 or 10 times, depending on which one you use. Can they turn around in a circle? Can they stand with their feet together? Can they stand in a semi-tandem stance? Can they stand in a tandem stance? Again, I wouldn't have, you know, a patient who I thought was a high risk for falls stand in a tandem stance unless there was someone there with them, or they were maybe standing at the sink or had their walker in front of them. So again, it's up to the clinician to identify the level of safety, you know, for the test or the questionnaire that you're doing with the patient. The tug test, timed up and go. So, you know, you ask a patient, hey, can you find a place in your home that's 10 feet? And I want you to sit down, walk to that spot, turn around, walk back. And I would just be timing them from my end. And again, the test stratifies fall risk based on, 30 seconds or more would be a high risk, 20 to 30 would be a moderate or mild, 10 to 20 would be a moderate, and anything below would be a low fall risk. So um, again, depression screening, so the pH Q2 or anything of the like. There's other things. The dynamic gait index is a great tool for assessing ambulation. Tenetti is another one that's good for assessing balance, or just a real simple 30-second chair to stand test. And that's a standardized test, and it's in the primary literature, and kind of gives you a baseline, and again stratifies the patient's risk for falling, and just assessing how many times they can stand up and sit down in 30 seconds. So I think Sue's probably started to do that right now, I would imagine, because she wants to know if she's a fall risk or not. Then with the telerehabilitation, again, it's no different than practicing in person in whatever setting you're in. Your assessment becomes your treatment. So if you assess that they had some weakness in their legs, then we're going to work on strengthening their legs. It's always about how and what's the best way. Is it with gravity, against gravity? And that's something that the physical therapist will be able to identify, with their assessment. Lots of different interventions that we can use and recommend over telerehabilitation. Obviously, our number one thing that we go to as physical therapists is exercise prescription. Physicians typically, they prescribe medications and tests, and we prescribe exercise. Maybe it's just lifestyle modification. So, a patient sleeps in their recliner chair. They stay in the recliner chair all day. They get up and go to the bathroom at noon because that's when they can. They go back to the recliner chair and they wait for someone to bring them a hot meal at dinner. Maybe their son or daughter brings them. So maybe it's just, hey, every 90 minutes, I want you to get up and I want you to walk around your house, however far, for 90 seconds. I want you to go out and prepare your own meal and not have someone serve it to you, whether you're setting it up at the counter and standing, or maybe you're setting it up at the kitchen table and sitting down and preparing your meal. It's just, looking at how you can increase their activity level. What assistive device are they using? Wheeled walker, standard walker, hemi walker, quad cane, wheelchair. I mean, you name it. What would be beneficial, what maybe they don't need. I think a lot of folks, my cousin's grandmother's son's brother told me that I needed to use this type of device. Well, it's not really necessary. So again, it's just really trying to engage that patient and get them to buy in and making those recommendations. Is it posture? I mean, can we just, again, patient sits in a recliner chair all day. Do they have lumbar support? They have a back pain or sciatica, whatever it may be, or they just have, edema. Are they laying with their legs in a dependent position all day? So looking at that, whether it's seated posture, standing posture, environmental changes, what can we do to modify the home? What can we do to make it safer? I have my blinds closed back here because it's raining out, but you would be surprised how many people do not open their blinds ever. And their curtains are pulled and it is just dark in their houses all the time, unless they have the television on or they happen to turn on the light. So, hey, open that blind, bring in that daylight, not only just for the light, but for the vitamin D, and potentially boost your mood, make it safer for mobility in your home. Pick up the rugs, things like that. Do you have a night light? If you're getting up at night to go to the bathroom, is there a night light to at least help you guide the way? when you do have to use the bathroom at night. So a lot of different things to look at. Establishing a home exercise program. So you can establish it, you can progress it, you can increase the frequency, the repetitions, you can add exercises to it. So, I mean, there's a lot of things that you can do with the home exercise program to get the patient moving in the right direction with their whatever's going on. And then, of course, the old standbys are ice, heat, and elevation. Compression can be put in there too. So, you know, someone with a bum ankle or a bad knee, even post-surgical, hey, are you icing? You know, do you have your leg up? Well, I put it up. Well, is it above your heart? Well, no, I can't get it that high. Well, let me show you how. You know, so let's educate the patient and, you know, just kind of stick to, you know, what we know works well with controlling, you know, pain, swelling, edema, things like that. Again, we talked a little bit about establishing a frequency and duration. You know, is it going to be one time per week for a month, or is it going to be 2 or 3 times a week for a month? Or is it something that we're going to kind of follow over the course of, you know, 8, 10, 12 weeks? And again, progressing the patient, you know, so they're walking 90 seconds, 5 times a day. Okay, I want you to walk 2 minutes, 5 times a day. Okay, now I want you to walk, you know, 3 minutes, 3 times a day. So again, it's just getting on a schedule and a plan, progressing it as appropriate, just to maximize their function, safety, and independence in their home. So I mean, as far as exercise prescription goes, I mean, we can do, you know, software system. There's YouTube videos you can reference. There's old-fashioned handouts that you can scan and email, or you can just put them in the snail mail. So there's a lot of different ways to follow up with the exercise prescription. Compliance is huge. I mean, I mentioned it earlier. You know, what if the patient isn't going to participate, or they're going to do it when they feel like it, the outcomes may not be as good as you anticipate. They may not feel as good as they should, and it may not say, you know, it may come to the point where the patient says, well, tele rehab, it doesn't work. Well, compliance is a huge part of that. And then limiting the number of interventions. Again, primary literature has found that 3 specific activities get them really compliant, and a really good routine is kind of that number, go-to number. And then, you know, as with anything else, if I'm seeing a patient in the clinic or in the hospital, it's, you know, that referral to, you know, I saw Dr. Drost up, you know, to the Center for Senior Health. Is it a referral to orthopedics? Is it a referral back to their PCP to really kind of see, you know, what else am I missing here? Is there something else that this patient would benefit from? Or have I kind of done everything that I can? I don't think it's a musculoskeletal injury. I don't think it's because, you know, she's clumsy. I think there's something else going on neurologically related, and she needs to be worked up by a neurologist. So really kind of doing that. And then kind of the last thing, you know, would be referring out to the community-based services. And I put Direction Home in yesterday, not knowing you guys were on the call, and do that all the time. So yeah, so that's rehabilitation in a nutshell. My favorite physical therapy quote is kind of hurts today, works tomorrow. So that is, here are my resources, and that is all that I have. So I will stop sharing, take questions,
Thank you
and we'll go from there.
Thank you so much.